This conference will now be recorded.
Okay, good evening and welcome to AnCan Low and Intermediate Risk Prostate Cancer Group for Monday, June 8th, 2026. My name is Stuart Jordan. I'm one of the co-moderators for this group. Bill is here, Rick is here, and Boykin may be joining us. So welcome to any of our first time, new time guys to our group. We're really nice to have you. Would like to mention that all AnCan groups are peer-to-peer support groups. And please do not take anything that we say as medical advice. We are not medical doctors. We're here to share our collective experience and answer questions and hope that we can provide you with information that we encourage you to discuss with your doctors and medical team. Before we begin, we would like to thank our sponsors who sponsor all of our prostate cancer groups. And Rick Novartis,
Yes.
Telix,
Yeah, almost.
almost.
We'll acknowledge them.
Yeah.
The checks in the mail. Look, can we say that?
Yeah, the check's in the mail. If that's what the boss says, then we're good.
Foundation Medicine.
Foundation Medicine, and Bayer. And no, not Bayer. Not
Blue Earth Diagnostics.
Novartis. Yeah.
Novartis, he said Blue Earth Diagnostics. We had a conversation with today.
Thank you very much.
And,
yes.
they seem to be very interested in helping us out. So,
And just also to mention for new folks, we have multiple prostate cancer groups. We have active surveillance for those who are considering, who have opted to postpone or avoid treatment. We have a couple of guys coming to us today that have been in there. We are low and intermediate risk for guys who are considering or have been treated. One of the things to mention is we do not talk about recurrence in this group, and we encourage you to instead join our high risk recurrent group, which meets tomorrow night and on Mondays as well. We also have special groups for veterans to help you navigate the VA system. We have a group for men under 60. We have a group for gay and bisexual men, and we have a group for European men. So we encourage you to check out all of our different support groups that we try and provide as much information as we can. So with that Bill, you're going to take over and talk to Carl.
Okay, Carl. So the way we run our groups is for new guys that we've never seen before. We have a short series of questions asking you about your diagnosis and your path to this point so far. So it's a good way for us to gather information from you and get a feel of where you're at and let the whole group hear what's going on, because you'll probably find that there'll be some parallels in the group with yourself. Not to shortchange you. I mean, if you're really interested in getting to the start of the game, we got to warn you. We want to help you out. So
it's okay. I can miss the start of the game.
All right. So first off, how old are you?
But I don't want to feel like I have to stay, even though you've been generous to me with letting me start first, which is really nice. It just happens to be tonight. I can't stay the whole time.
Yeah. We understand that. Nobody has to stay for the whole meeting ever, except the moderators. So how old are you?
I'm 65.
65. All right. And when were you first diagnosed?
March of 2025. So that's a year and 3 months.
A year ago. Okay. And where do you live, by the way?
Albany, New York.
Albany, New York. You did say you were a New Yorker. Just out of curiosity, how'd you hear about us?
I have no idea.
You don't know?
I honestly don't remember. The last
that's all right.
15 months, like most people who are new to the cancer experience has been a bit of a blur. So I honestly don't know where I came across AnCan.
No, that's fine. Are you a veteran by any chance?
Nope.
All right, because as Stuart mentioned, we do have several
But I am
veteran-specific.
bisexual, and I would consider going to the gay and bi group.
Okay. Yeah, well, that
Whenever,
information.
whenever.
Those group, they read
It's
on a
not.
weekend.
It's not. To
so-
me, that's not the reason I'm here.
No, that's fine. So, when you were first diagnosed back in March, what was the pathway that happened? Did you have a PSA rise?
Yeah, I've been having higher PSAs for a couple of years. My father died of prostate cancer, which was not diagnosed until it had already metastasized to his bones and I think his kidney. And then he fought it for 8.5 years and he died. And then lo and behold, like about 9 years later, I got the same bad news. So that was a blow. And the PSA was rather low in terms of what the doctors were saying I should be worried about. It was like 6.9. So
Okay.
I was encouraged to do active surveillance, and I basically said "F you" to
All right,
everybody here in Albany. Said that.
Yeah, so after you got the 6.9, they suggested active surveillance. Well, what was your next step? Did you get an MRI?
Well, no, they didn't suggest. I skipped a couple things. They didn't suggest active surveillance until they did an MRI followed by a biopsy right here in Albany at Albany Medical Center.
And that MRI, that biopsy was the MRI
Yeah,
guided
well, I'm telling the
biopsy?
story backwards, right? The MRI and then the biopsy, all that stuff happened before they confirmed that it was cancer. So that all led up to March of 2025, but they said, Carl, you have cancer. And we had a
Right.
series of meetings by video, and which the urology team at Albany Medical Center recommended active surveillance. And they gave me the other two alternatives, chemo and radiation,
Well,
which made no sense given how low I was.
Let's take a step back. So you got the MRI fusion guided biopsy. Also, out of curiosity, was that a transrectal or transperineal biopsy?
I don't. Oh, the biopsy?
Yeah. Did they go through your rectum or did they go through your perineum?
I believe they went through the rectum.
Okay.
And I was awake for the one at Albany Medical Center. With my legs
Yeah,
spread,
I
all
was
like
awake for
medieval
mine.
torture chamber thing.
I was awake for mine too. I didn't enjoy
I didn't
it.
mind. I didn't mind. I found that machine fascinating because they
So-
clamp your legs in case you start, having a muscle reaction.
Right.
And it was like a medieval torture chamber, but it didn't bother me. That didn't bother me.
Okay. So
What did
back to
bother
the-
me?
Okay, I was going to say, let's get back to the diagnosis. If they recommended active surveillance, yeah, I'm assuming you had some pretty low-grade cancer with the cores that they took, or
Yeah, I can't tell you what the Gleason score was, but it was low enough that they thought I might be okay with active surveillance for a year or two, and I rejected that.
so you don't know any of your Gleason scores.
What?
You don't know what any of your Gleason scores were.
I
from
don't
the
remember it because what
biopsy.
happened is I got referred to Sloan Kettering. I found a doctor at Memorial Sloan Kettering who does cryoablation, and he determined after his own biopsy that I was a good candidate for cryoablation, which means freezing the cancerous area to try and get
Right.
rid of it, but preserve the rest of the prostate. And that process started July and August. And then I got approved after whatever tests he had me do, and I got on a list and a date, and I had my cryoablation in the beginning of December, and that was it. And other than a week of a catheter, that was it. And then they put me on finasteride, which I didn't like. I had a horrible reaction to that. Other than the finasteride and the catheter, I really had no problems after the cryoablation. Then I got my PSA in, I guess, March, and I'm down to 0.83 or something, or 0.083. Very, very low now. Very, very low. So I'm cancer free. It's just remarkable.
Okay. So you've already chosen a treatment path. A lot of guys that come into our group as new are a little ways back to the left than you. They're looking to decide on a treatment path. So
Yeah.
since you've already had cryoablation and your PSA is now 0.083, what led you to our group? I mean, what can we do for
Well,
you?
it's been a very hard year for me. It's part of the aging process. It's affected my marriage. It's affected my social life. It's affected my mood. And it's been a very hard year. I haven't come to terms with the idea that I have cancer. And the reality is, even though I'm now cancer free, I still have the cancer diagnosis. It's been a tough year for me. I haven't really wanted to share with it in this kind of a fashion. I talked about it a little bit on my social media because I'm a
Right.
prolific social media person, but that's very different because I can turn that on and off. But it's very different to actually talk to other cancer warriors. I just haven't had the inclination to share with anyone. Dr. Feinberg is my hero. I'm fighting this battle, and I have a laser focus, no pun intended, on hashtag fuck cancer. That's how I feel. And anything that's not relevant or necessary to my personal quest, I just haven't seen the need for. But this morning, I just spontaneously decided, oh, look, there's the AnCan meeting that I've been ignoring for a year. Let me try it and see how I feel. I'm
So
very angry. I'll
Dr.
be honest with you, Bill. I'm a very angry person about cancer. I'm not going to be an easy group member here because I have a lot of unresolved emotions. I'm in therapy, but
Yeah.
this is not an
So
easy thing for me to share.
I was going to suggest, Carl, like I said, this group is men looking to make a treatment decision path, which you've already
Right.
done. We have another
Okay.
group called Men Speaking Freely. And as you suggested, we also have the gay and bi group. If you're interested in joining them, those are all on our calendars. Stuart will put a link to our calendar at our website. If you've not already visited it, I know that you have signed up for some of our groups already, right?
Well, what happened was I got all these emails, and I've just been so busy that I finally decided I saw repeated invitations to the low and moderate group, and somehow I thought, well, I was low risk before I had my procedure, so I really didn't know if this would be appropriate. But there's such a stigma attached to prostate cancer, and it's taken me this long to be willing to share with anybody about it. But I'd be happy to try those other groups, given that I've already gone through the journey of treatment.
And don't think in any way that I'm shuffling you off. I'm just letting you know that there's other resources at AnCan that will help you out also. It's fine for you to come here because this is a first step for you, and that's excellent. All the guys here can feel for you exactly. I think if the other guys, anybody wants to speak up and tell Carl.
I just have to put one other word out there, and then I want to zip it and listen, because I shouldn't leave at 8:30. Now that I've said a lot, you guys have heard a little bit about me. I'm the one who put the white sheet over my dad's dead body. I'm not a military veteran. I've never seen a dead body. My father passed October 1st, 2016 at the age of 88 and a half from prostate cancer that had spread to his bones. He fought 8.5 years valiantly. It was a very traumatic experience that somehow or other my mom was left with my father's dead body. And when I arrived half an hour later, they hadn't covered him. And that's what crystallized it for me when I told Albany Med that I was not going to do active surveillance, that I had to find a treatment option now. They didn't really know how to react to me, so they referred to me to Sloan Kettering. And it took a while before I found a doctor who was willing to hear the emotion, which was rage, confusion, fear, and just laser focus on let's get rid of this thing and let's do it. But I'm still very, very shook up by this, very shook up by it. And I just want to listen now because I think I've said probably too much.
Yeah, I understand. We can understand that. Rick wants to say something because Rick and I actually discussed those of us that are a bit further along the journey path and some of our philosophies in life. I don't know what Rick's going to say, but go ahead, Rick.
So the issue that you're raising is quite close to some discussions we've been having recently, which arose mostly out of something that was written as an introduction for our Men Speaking Freely group, which is sort of a sister or a brother, it's probably a better expression, to what you're experiencing, which is the fear of recurrence. So there's a lot of people that are concerned about recurrence. There's a lot of people who are angry and have treatment regret, which you don't. And there are some people that we experience who just angry at having gotten diagnosed. Everybody in this room has received a diagnosis. And I think we can help you in this room. And I'd love to open this out. I think we should open it out to anybody who relates to what you're saying. And I really encourage you to attend a Men Speaking Freely group and speak up and bring this issue up, because there is so much wisdom in that group and people who feel the same way. I'm thinking in particular of one gent who is a medical professional himself. He's older, and I think he would identify with you very, very, very closely. So I know we could get a great discussion going on in there. And discussion is what we want, because that's what helps us process, and it's cathartic. So let me throw this out first of all to anybody, which is anyone else sitting in this room right now, and there may not be anybody who's angry about just having gotten cancer, just having gotten the diagnosis. There's a hands up function at the bottom, by the way, Carl, and we try to use that because it helps us. But anybody stick their hand up if you were angry just about being diagnosed. So step one, no. But that's it. That ain't going to happen in the Men Speaking Freely group, I guarantee, because I'm thinking of the people that will respond to you. Now, next question. Anybody here in this group who didn't feel it themselves but relates to that anger that Carl is experiencing? Does anybody get it in this group right now?
Well, I'll definitely speak up, Rick. I was going to let someone else jump in, because as the moderator, I get to speak plenty. But from an anger viewpoint, Carl, I was diagnosed in 2015, so over 11 years ago, and I am the seventh of 8 children, and I have 5 older brothers. So I was the first one diagnosed with prostate cancer at the age of 51. Right, I think I was right on the edge of 52. Right, so, and I, never ever in any way, shape, or form would I wish prostate cancer on my brothers. But in my mind, it was like, well, why the hell am I getting diagnosed with cancer when I've got 5 older brothers? It was kind of like unfair. But again, not that I would wish it on my brothers. I love all of them, assholes they may be at different points in time. But so I can really relate to the anger part, but I think everybody goes through at least a little bit of that when they get a diagnosis of cancer, because you're thinking, I would say 99.49% of people say, I gotta deal with this. And anger is one of the things that comes out, because you're like, why me? Why do I have to deal with this? This is some bullshit. But yeah, so definitely can relate to the anger part, having been diagnosed at a bit of a younger age and dealing with that. But I can say that from what you've told us, looks like you've got a pretty good prognosis. And if your father was diagnosed with late stage, you've caught it early. And
Yeah.
I think a bunch of men in this room will tell you that not a lot of doctors off the bat recommend active surveillance. Most of them, the first thing they go to is treatment, even with low grade, a lower Gleason score. So if you had doctors that were already offering active surveillance, you don't have your Gleason scores, but I'm assuming they were low. You were grade group 1 or 2 at the most, with a 3+4/7. So you're probably in a pretty good place.
I'm still angry. Just the reason I didn't come to a meeting like this is I knew it would stir up a lot of emotion, and it has. So I'm just being honest.
Yeah,
I could talk all night about it, but again, like you said, I'm probably in the wrong group because I've already taken the leap into treatment.
No, you're not in the wrong group. You're not in the wrong group. You're not. I mean, because you haven't recurred, you've had treatment. This is exactly the right group
Right.
for you.
And by the way, I'm not going to be able to go to the Thursday group because I found a new therapist and we're locked in Thursday nights at 6:30. And the speaking freely is 8 o'clock. And my therapy is virtual. I just cannot commit
Okay, well,
hours.
you know that we can only offer. It's you can figure out, and if you come into
Yeah.
that speaking freely group late, we'll still welcome you. You can come in anytime you want. But I will
Well, you're
say
very kind. Thank you.
that the peer support that you might get in that group will be a whole different flavor to your therapy, and likely very, very positive. So it might be worth like dipping your toe in and just hearing. I've got the David who is wrestling with his his headphones in public, has put a question in, and it's a great question for you. It's in the chat, and he says, can I ask what the complications and consequences of cryotherapy? I'm intermediate risk by, according to Decipher, and he goes on to give some other issues, some other descriptions of himself. I would have a comment to David on that, but why don't you talk to him first?
Who, me?
Yes, he wants to
Oh,
know
no, no,
what
no, no, no.
complications are from.
I'm an idiot with all this stuff. I'm an idiot with all this stuff. I cannot answer those questions. I would ask I'm going to see Dr. Jonathan Feinberg later this month, and I just let him explain to me the correct answer. I'm a lawyer and I'm brilliant at what I do, but with cancer, it's all about my emotion and all about focusing in on my own
Well,
situation. I can't possibly tell
did
him
you did
what
you
his
have did you have
experience would
any
be.
complications or consequences from your cryotherapy?
Uh, very, very minimal. I had blood in the urine and the stool for maybe half a week. I had that darn catheter, which I couldn't stand. I've never had a catheter before. Luckily, I've never needed one for anything. I've been very healthy. The catheter alone was a bitch. And I know this is not relevant to cryoablation, but my first biopsy, they said no ejaculation for 2 weeks. And I ignored it and I masturbated. And to my horror, blood came out onto the floor. And they hadn't explained it to me. And I was furious. My wife was sympathetic, but she said, well, men are squeamish about blood. And I started to talk with guys I know at the gym because I'm very open. I just blab. And people were like, holy shit. And then a guy would be, you got to come over here. This guy had a prostate biopsy and blood coming out of his dick instead of semen. And they were all like, oh my God. And the doctors did not prepare me for stuff like that. Now, I can't answer David's questions, but I can tell you that my urology doctor at Albany Med was, I did not think, sophisticated. Compared to Memorial Sloan Kettering, one of the top cancer hospitals in the world, I was so fortunate to find a team at Sloan Kettering that I could, drive to New York City to work with and then use them. And we also have a friend who is a brilliant physician and very, very knowledgeable because he's like an academic. He would teach doctors, professor of cardiac medicine, but he reads everything. He gave me we just have friends who are intelligent and helpful. I just
Okay.
don't have answers to David's questions.
Okay, no, David's questions are good, and I'm sure he's got what he wants. And David, come on, when we've gone through the new guys, come on, ask that question again, and we'll give you a little bit of guidance on the cryoablation. I am guessing, I'm not certain, but I am guessing that Carl's cryoablation treatment was focal, meaning
Focal, right.
So it was focal and it was aimed at a part of the prostate. And I would say that focal therapy is not something you should be considering with a 4+3. I certainly wouldn't consider it with a 4+3. But again, we don't give you medical advice, but 4+3s are not good candidates for focal therapy. So.
And I mean, again, I cannot, David, I can tell you the what was not the complication. I have been able to resume normal urine, normal bowel, normal erectile function and ejaculation. And that happened within maybe 3 months. And now I'm 6 months from the procedure. It's almost like I never had it, which is weird. So I never thought it would be that good. And let's hope that when I do my next biopsy in December, I continue this path. I just don't know.
Yeah.
I put all my trust in Dr. Jonathan Feinberg. That's all I can say. I know it sounds like a broken record.
No, that's good. I was gonna mention one other thing, Carl, that since your father had advanced prostate cancer and you also developed prostate cancer, if you haven't already, you should probably look into getting some sort of genetic testing. So,
With a view towards what?
whether or not you have any markers for prostate cancer or
Oh,
any of
I
the
assume
other.
I do. My son is 20 years old, and I've already told him you're going to have to really monitor your PSA. But
Well, that's
what
another
would be
good
the
reason. You have
what
a
would be
son.
the
Another
point?
good reason. Well, if you
Well,
have genetic markers for prostate cancer, then
Yeah.
you could definitely have passed those on to your son, and he should probably get genetic testing also.
Yeah. My brother is also high risk. He's had BPH, benign prostate enlargement. He's the one that prompted me to start getting my PSA tested. Had he not pushed me 3 years ago,
So
I wouldn't be sitting here.
we're going to have to move on real short.
Yeah, please do. Please do.
But let me just say that I think the point we're making is you may have inherited mutations from your father that you could
Yes.
pass along to your son. So when
Yes.
you see Feinberg, tell him that you'd like to get an inherited mutation test, and he will
That's
say,
a great idea.
that's just
Yeah.
fine. What a good idea. I'm sorry I didn't suggest it. Well, he may
It's
not
almost
say, I'm sorry I didn't suggest it, but he's a good
Well.
doctor. We know of him. And so that's what we'd say.
Yeah, I'm going to write that down.
I did see Dr. Mark wince slightly when you mentioned you're getting a biopsy in 6 months. That's a little unusual, but I guess if they didn't treat a decent amount of the prostate, there's probably reason to do it. So come back and talk to us.
Okay.
Yeah, come back and talk to us, Carla. And again, getting the genetic test is usually it's either a blood test or a cheek swab. And I'd tell your brother to get one too, personally.
I think he's already had it.
All right, good. Now, unfortunately, me and several of my brothers have had the genetic testing. We have no inherited genetic markers for prostate cancer, and my father had prostate cancer, and my maternal grandfather had prostate cancer, and one of my brothers is on active surveillance for prostate cancer. So get the test anyway, right? Because if you do come back with something positive, it could guide treatment down the road if God forbid anything comes back or comes up again.
And then make a little more money for Sloan Kettering because they already did quite well for my insurance.
It's a cheap test. They won't make that much off you. All right. Well, like Rick said, come back again. Let us know what's going on, and we'll be happy to talk to you.
I want to hear from someone else. I feel like I'm doing all this talking, so I'm going to mute and listen.
We did have a individual named Eric from Atlanta who is, I believe, brand new. You got in just under the wire, Eric, right before Stuart started the recording. So if the other gentlemen don't mind, I'd like to go to Eric as a brand new person versus the guys from active surveillance. Is that all right? I'm assuming. All right, no silence is consent, as we used to say in the military. So. All right, Eric, you're up.
It's funny that I show coming from Atlanta. I'm actually in Portland, Oregon, but that isn't so important. Yeah,
right,
do you want to ask questions to me? Maybe that's more efficient, or?
Yeah, that's more efficient because we'll hit the high points. So you're from Portland, Oregon. How old are you, Eric?
55.
All right. I feel you.
And I did get the other group, yeah,
Yeah. When were you diagnosed?
about 2 months ago.
2 months ago. So what was that? April?
About that, yeah, April 7th, 10th, yeah.
And what led up to your diagnosis? Did you went to see a doctor for
No, I had a
PSA,
friend,
BPH,
I had
something?
a friend who's more or less my age who got diagnosed with prostate cancer. And so he said, hey, get your PSA tested. So I said, oh yeah, okay, I probably should do that. So I did. It wasn't so high, about 4.5.
Okay.
And then to continue, I mean, I heard your other questioning. So then I had a digital exam since it was a little bit high. He said, yeah, it seems a little bit enlarged. Then they did the MRI. After the MRI, there were some
All right.
signs of potential cancer there, enlargement, et
Did
cetera.
when they did the MRI, did they found lesions? And did they give you a PIRAD score?
I don't know about that. I'd have to go look in my chart. I don't remember any talk of lesions, or I don't remember that score name.
So you said if they said that they saw some indication of prostate cancer, then they would have
They
said
saw some
they
enlargement and
saw
they
a
saw
lesion, right? Something lit up on the MRI. So
okay,
so
something lit up.
that led them to driving you toward a biopsy, right?
Yes,
Was that transrectal or transperineal or?
rectal.
You got to get away from those transrectals, man.
Yes, felt like they shoved a little
And what?
Tonka truck up my ass. I was very uncomfortable. I didn't mind them shooting. I watched the monitors. They were shooting the needles in, but man, anyway.
Yeah. To me, the hard part was that every time that needle snapped, right, and then after like the first few of them, and then I'm just anticipating the next one. So I was like getting really super anxious, and then it'd catch me by surprise. So the nurse wanted to help out, and after I was sitting there sweating for I don't know how long, she goes, "Okay, we're about halfway there." I was like, "Jesus, did you have to tell me that?" So that's enough about me, right? So, what were the results of your biopsy, Eric?
Gleason 7, 4+3.
Do you know how many cores they found?
13 cores, 7 were 4+3, 6 were 3+4.
7 were 4+3. So you had 13 positive cores.
Yes, I guess so. I didn't know
Okay.
they were non-positive cores.
Oh yeah. There is such a thing as non-positive cores. Guys come in here and they had 1 or 2 positive cores, with a very small amount. Did the biopsy report give you an indication of how much, like a percentage wise of each core was the 4+3 or the 4? It's probably in your report, but if you don't have it, that's fine.
I have the report, but I'm not so good at reading it. So it says, let's see, 1 of 1 core, 30% grade 4.
Okay.
80% grade 4, 10% grade 4. Should I keep going or?
Well, no, I mean, if you had 13 positive cores, they pretty much found it everywhere they looked, right?
I guess so.
You know how many cores they did total?
13.
They did 13 cores and every single one was positive?
I think so. 30% grade 4, 80% grade 4, 10% grade 4, 60. Yeah, all of 10% grade 4. Yeah, all of them have grade 4 or 3 after it. So I guess so.
Okay. All right. That's
Oh no,
actually
none of them say grade 3. They all say grade 4.
all 13 say grade 4?
Yeah.
Well, Rick turned his camera off. I don't know if he's there, but
But actually, maybe I'm not sure that I'm reading this right. So
Mark, go ahead. Mark's got his hand up.
It may be grade and not the Gleason score if they're just giving you one number.
Yeah.
So all of them have a score of 7, and then some are 3, like I mentioned, some are 3-4, some are 4-3.
Right.
Yeah.
But
So I don't know.
what we're trying to determine there is that you have 13 grade 7s on your biopsy report. Is that correct?
Yes.
Okay.
If I'm reading this right, yeah.
Well, I'll refer to Rick and Mark both. I mean, I don't think we've ever had anybody in a group say that before.
So it could be that I can't. Can you give me permission to share the screen and I can show you the report? Or
I'm not.
don't know. I don't think we'd be able to see it very well.
Yeah, it would be hard to see, but yes, I've certainly seen it before. I suspect that it was targeted. The question is where these were taken from. If they were taken from both sides, if they were all taken from the target, and they, which would be unusual because they'd usually take 2 or 3 outside the target. But I think the issue is it's clear that you're designated for treatment. I think that there's probably good reason to have those cores reread. We haven't talked to you yet about the biopsy, but we will, because there's going to be important information in that biopsy report that we'll ask you to look for. But the concern that I have is we really want to get a second opinion on the highest grade that you had in there, because whilst it may not be important immediately, it could be important down the road. And
So Eric,
we'll help you with that. So I'll turn it back to Bill or Stuart.
So Eric, when you came in, Head Stewart indicated that at the top of the chat window there were a couple of resources, a few resources on second opinions for prostate cancer biopsies.
Maybe I came in too late to see that.
No.
Yeah, I mean, if you go to do you know where the chat window is? The 2 little speech
Yeah,
bubbles, and
yeah.
if you click on that and then click on the push pin, you may see them at the top of the thing. But we can repost them if you don't see them. But we used to list a bunch of resources here, but we consolidated them all on our website. So now they're on our website. So, and these are links to our website. I don't know if you see them or not, but
I see them, and I've clicked on prostate cancer and GU pathology second opinions.
right. Yeah. If you click on that or copy it, either one. If you click on it, it'll open a web page for you. If you copy it, you can look at it later. So
got it.
So Jonathan Epstein and I forgot Dr. Zhou's first name, but
Ming Zhao.
Yeah, Ming Zhao, because my urologist was Xia Zhao, so I get them mixed up. So, but yeah, they're 2 of the best pathologists in the country. Dr. Epstein trained Dr. Zhao anyway, but so he's his protege.
I filled out the form on his website. I called I'm with Kaiser. It wasn't clear to me how to get the information. I wasn't clear exactly what information I needed to provide to Epstein. Like I didn't know if it was the reports that I already have or something else, but I have started that process.
Okay. So I'm a former Kaiser patient myself, and I empathize with you. Oh. It's not easy. That said, yes, you'll probably have to pay for it out of pocket. Thank God it's not very expensive. At the same time, you just have to get the Kaiser pathologist to send the slides to Dr. Epstein's lab. And now, in terms of treatment and who to, we can probably do a little bit of poking around for you and see if there are better urologists than others, or urological oncologists or others in the Portland system. I don't know the Portland system, the Kaiser Portland system at all. But I would be looking very much at who all of the urologists are, and if any of them seem to have better experience than others, because it's not hard to transfer from one doctor to another in the Kaiser system. You don't offend anybody if you decide you want to do that. But as part of being your own best advocate, do check out those docs. My own urologist, who still technically is my urologist, who is really a great guy, is in Northern California. I'm not anymore. But we can reach out to him and ask him if he knows any of the Portland docs, but it's probably not that likely. But I really encourage you to do your homework and don't just take the first doc you get assigned to, since most likely, unless there are reasons otherwise, you're going to be looking at a prostatectomy. Have they done any additional scanning?
I had a bone scan done, which was clear, and that's it.
Okay. How close to the edge of the gland are your other lesions?
So I don't know how to answer that. Like,
Have they told you that the lesions are abutting the edge of the gland?
When I asked, so I was asking about, lifestyle things like erectile dysfunction and incontinence, right? And they said, well, when there are great margins, then it's easier to do the prostatectomy, for example, and feel like they can leave the nerves. He said yours are close, so I don't know that it's not outside, but I think they may be close, but I can't.
They may be close. So I get what the reason I'm driving at here is you obviously have a lot of cancer. You have bulk. So we just want to make sure, and also this is why I'd like to get a second opinion if it were me, because I'd like to be sure there are no 4s or 5. There are no 4+4s or 4+5s in there. If there were 4+4s and 4+5s, I think you'd have a good case to make to get a PSMA scan. In Kaiser, it's very hard to get a PSMA scan.
What is a PSMA scan?
What is a PSMA scan? A PSMA scan is done where we think the cancer, in your situation, this is why it's done. In other situations, it's done for other reasons. But in your situation, it is done where the cancer seems pretty aggressive. There's a fair amount, and we just want to be sure that none of it has gotten outside of the prostate gland. Because the bone scan itself, or even other forms of CT scan, are not sensitive enough to give us that information. So if there's a lot of cancer and there was there may be action in some of the lymph nodes. If there are action in some of the lymph nodes, it may change our decisions. And when they first approved these PSMA scans, one of the major clinical trials they did was for people like yourself, and so that they make the correct treatment decision. Because the PSMA scan can change the treatment decision. Now, in a health, an HMO like yours, they're not going to offer you a PSMA unless they have very good reason to. And that's why we want you to be your best advocate. So,
yeah, advocate for it yourself versus wait for someone to mention it, right? David, you had your hand up?
Yeah. Hi, Eric. I'm in Portland too, by the way.
Oh,
and I was where you are now about 1.5 years ago. So I know what that's like. And I also had a 4+3. And I'm wondering on your biopsy report if there are any words like cribriform. Do you see any words like that on there? Cribriform?
Yeah.
No, and let me just read one of them in total just to make sure. It's like it says prostrate, right base lateral, needle core biopsy, prostatic and adenocarcinoma, Gleason 3+4, 7, 35% of tissue. So they're all pretty much like that. And then it has like the right base medial, the right mid medial, etc. But I don't see that No, I don't see that word.
You don't see it
Say the
anywhere.
word. Say the word again, please.
Cribriform, CRIB would be the first four letters.
Yeah,
Introductal would be another one to look for. These would just be weird types of cancer cells that might make it more aggressive.
oh wait, here we go. Here we go. Histologic features of cribriform carcinoma and introductal carcinoma are not identified in the specimen.
Okay, good, good.
That's a good thing.
Yeah, that's a good thing.
That's a good thing. But you mentioned something that concerns me. How many of these cores are in the base?
Let's see. Right apex lateral, right apex medial, left base lateral, left base medial, left mid lateral, left mid medial, left apex lateral. Looks like
Two.
yeah, two, I guess.
And those two are 4+3s or 3+4s?
I'm sorry, I think I wasn't at the top. Right base lateral, 3+4. Right base medial, 4+3.
Okay, I hear enough. So you've got right and left. The cores that are in the base are more serious than cores that are not in the base.
Uh-huh.
And the reason for that is because the prostate is sort of upside down. So the base is the top of the prostate and the apex is the bottom of the prostate.
Hmm.
Although that's not really what it is, because if you took a prostate and you took a prostate like this and stood it up, this would be the base, this would be the apex, but actually in the body it's like this, it's upside down. We are concerned about base because that's where it attaches to the bladder. So if you have 4+3s in the base, it's a concern to us because it means that it could have gotten into the bladder. And that's probably a good argument as to why you want a PSMA scan. So you can use that as an argument for a PSMA scan. We also need to see what Dr. Epstein says about those cores and if he agrees. But whilst we don't hear cribriform and we don't hear introductal, that's what I'm picking up from what you're saying, which would be a concern to me that you need to dig down with it. And the surgeon's going to say, well, yeah, we'll take a good margin there, but there's only so much margin they can take from the base because it's right up against the bladder. Dr. Mark, would you like to embellish on that as a surgeon?
Yes. You've got one chance, Eric, to do it right. And the first strike against you is a Kaiser insurance company. And you have to decide whether you're okay doing what's best for Kaiser or if you're okay spinning the dice or rolling the dice and hopefully things would be okay. Now, Rick said about doing the second reading on the biopsy. Dr. Zhao and Dr. Epstein, who are the experts, report 30% of the biopsies that they review are changed. Sometimes they're less, sometimes they're more. If you're relying on a local doctor, you're rolling the dice. The next thing is they did a transrectal biopsy, which is still done all too frequently in this country. In more awake places like Europe, the idea of someone dying from an infection is something that they don't want to see. So they've stopped generally doing the biopsies through the rectum. They're doing the transperineal biopsy. It's a bit more expensive because generally you're going to get sedation with it, but it's far more safer. You're talking about anywhere from 2 to 4% having serious threatening and life-threatening infections that may require hospitalizations. So going back to the person earlier, I'd want to know for sure that you really need another biopsy before they do that. The next is if they left you thinking that the bone scan is going to tell you whether it's spread. By the time it gets there, you'll have other evidence that it might have spread. To say that the bone scan is sufficient, to say that an MRI is sufficient, it may show it, but it's not the PET scan. And anything other than that in someone with 4+3 is cutting corners. So, I mean, when I look at this, I see that they're really treating things for Kaiser and not for you. And it's worth taking what money it's going to take and get an opinion from someone who specializes in treating prostate cancer and not in the financial aspects of it. Because I'm 5 years out now. I did radiation therapy for 4+3, no symptoms, PSA undetectable. I'm back on testosterone therapy, and I never had a catheter, never had any problems with it. So I think now is the time to take this in your hand and spend some money if you've got it and get another opinion. It may be that they can arm you with the information you need to get the care you need through the Kaiser system. But if Kaiser does it wrong and rushes you to surgery, and the guy there didn't really know what cribriform was and missed it, you could opt for surgery, which can have a 3 times higher rate of recurrence than radiation if the cribriform is present. So that's my 2 cents. Do it right. You got a lot of people in the group here, and they all have some horror stories. If they've started out with the Kaiser system, you got to be aggressive.
So in terms of next steps, you would say get the biopsy sent to Dr. Epstein or the other doctor, start there, and then perhaps advocate even right away or at least after. The turnaround for the second opinion on the biopsies is pretty quick, isn't it?
It's very quick.
Yeah.
And it would probably take you that long. I mean, it depends on how quickly you can get the specimens from Kaiser to get them shipped off. But it may also be a while before you can get in for that second opinion. You have time to get the second opinion. It's more important that you get an opinion from someone who's going to provide you all the options and be honest with you about risks and benefits than doing it quickly.
And when you say second opinion, so now you're not talking about Dr. Epstein looking at the biopsy. You're talking.
No, Rick, you probably know people closer to Portland that he can see that would give him, an honest opinion about what the state of the art is now.
Yes, I do. And I'm sure that David does too. David Sharp, our David in Portland, David, who's been exceptionally helpful. I encourage you guys to exchange emails. Eric, are you in our system, by the way? Have you signed up for our to get emails reminders from us?
I don't know that I have. I'm not sure, to tell you the truth.
So make sure you put your email in the chat. You can do it to everybody. You can send it to me. You can send it to David. David will send it to me. We want to put you in this. We want to put you in this. Okay, that's terrific. And I do have some ideas which I'm thinking about, but I don't want to invoke them until you get the second opinion from Epstein. I think that's really, really important. And once we get that second opinion from Epstein, we can guide you on getting a second treatment opinion. And I actually have somebody in mind. I wouldn't normally take this step, but I do have somebody in mind, and I think we can get you a really decent. But again, it's going to be outside Kaiser, and so you're going to have to fork up to get a second opinion. Very hard to get second opinions in the Kaiser system.
Yeah, I asked the proctologist who does the biopsy. I asked about getting a second reading on those because I had already heard that, and I think he said he would do it, but then I never got anything. So I think it was just kind of shined on.
No,
Yeah.
I mean, if you're going to get a second opinion in the Kaiser system, we need to direct you where to get that second opinion. So, for example, and I don't know if they'll do it now. They would, at one time, you could go outside of Oregon, or you could go outside of your area, but now you may not be able to do it. But there are doctors in the Kaiser system in Northern California that we would recommend that for a second opinion. But Oregon may say, "Oh no, we don't do that anymore. You got to stay in here." And I don't have the people in the local people.
Eric, I thought you said proctologist, but it's a pathologist that looks at the biopsies. A proctologist is looking at a different part of your body.
Exactly. His name is Dr. Proctor. So and he is
Oh,
stuck the Tonka truck up my ass. So,
hopefully you have no need of a proctologist either. So.
Yeah. But I look, you have time. I mean, I was a 4+4 diagnosed at Kaiser. They gave me 4 months to make a decision. So you have time. Don't worry about that. But I want you to take this relatively seriously because there's a lot of cancer in there. It's all around the base. And that is a red flag. And frankly, your doctor should have discussed that with you at Kaiser. And the fact that they haven't, you can go back and say, look, I'm learning stuff. You don't have to tell them where you learned it, but we're learning stuff. And I really want a PSMA. And they say, oh, you don't need a PSMA. And, you're not. And you say, well, maybe I do, because I got a lot of cancer right around that bladder neck. And he's going to look at you and figure, and, oh, really? Because he hasn't told you that. And that's gonna give him a signal that you know what you're talking about. You get my gist, right?
Yes, very much so.
Say, Rick, I wanted to ask you something. You mentioned surgery a couple of times. Does Kaiser have a bias in favor of surgery over radiation?
No, they do not. Even though I know that it's very, very debatable, and Dr. Mark has left, so he's not going to jump down my throat, I still think that with younger men, there is good reason to consider surgery over radiation, but not as much as we used to think. So you could still be a very good candidate for radiation. The doctors, the urologists are going to tell you, but that's why I'm thinking I'm going to send you to a medical oncologist who doesn't have an axe to grind, who's going to tell you what they think. And I would stake my life on, literally, on the opinion of this radiologist, this medical oncologist in Portland. David knows who I'm talking about. Probably one of the best prostate cancer medical oncologists in the country. But we can make it happen, but you'd have to go there privately. You'd have to go to OHSU privately.
Yeah, I'm willing to do that. I did hear that Dr. Amling, is that someone? Something like that?
No, Amling's the urological oncologist there. And he may be good for a second opinion, but I want somebody who's not going to be saying, oh, I'm a surgeon, I'm going to cut. I'm a radiologist, I'm going to cut. I want somebody who's going to say to you, this is the best treatment for you. And this person is now the big boss for all the GU, for all of the genitourinary cancers, including prostate. And so from that point of view, they will have an opinion, especially given your age, as to whether they agree that surgery is right. But David, please speak up and please feel free to contradict me.
Well, I see where you're going with the age issue. The reason I bring up radiation is only because, like Eric, I had a 4+3. And Eric, there's a thing called the Sloan Kettering nomogram, which is a calculator that essentially gives you your odds of success if you undergo prostate cancer surgery, and you feed into this calculator your particular diagnostic numbers. And I just looked up mine. I had a 4+3, and so this calculator assumes you're wanting to know how effective surgery would be. And for me, it said that at 5 years post surgery, my chance of progression free probability, in other words, the cancer hasn't come back at 5 years, was only 47%. And at 10 years, it was only 31%.
Right.
So those are kind of low. And I've seen much better numbers with radiation. But
Right. So,
then again, I was 66 and not 55.
right. Can I just say, I would have gotten to that, but I don't want to get there, and I don't want Eric to run these numbers until we have the second opinion.
Yeah, that's
so
true.
I would say don't be running these numbers right now. I mean, we can, Stuart's put the nomogram in there right now. It's in there, but you're not ready to run it. Or if you are, you've definitely got to rerun it. In my own case, I only had a 30% chance of success. I was 56 when I was diagnosed. So much like you, I only had a 30% chance of success from surgery, and a 70% likelihood that I would need more treatment after surgery. And I will tell you that the first day I walked in to see my urologist at Kaiser, he gave me the MSKCC nomogram. That's how good he was. And in the end, I decided not to do the surgery. I did a lot of treatment instead, but it's been good, knock on wood, it's held. But we definitely would have you run that MSKCC nomogram, but I don't think we're ready to do it yet because we want to see what comes back. And the other issue with the nomogram is it doesn't take into account factors. It's been around for many, many years. What it is a huge database of experience from people who have had surgery at MSKCC, and then they match your disease demographics to that, and they can look at the outcome. So it may not be true for you, but they don't have things like crib reform in there because we've really only been talking crib reform the last 6 or 7 or 8 years.
And I was gonna mention this. I'm sorry, Rick. I didn't mean to cut you off. I was gonna mention the same thing. It's been around for a long time, and there's outliers, Eric. So it's not a. You do it and take the numbers to heart and follow it. So mine was my MSK homogram was like a 50-50 chance. That was 11 years ago. I had a prostatectomy. I had disease similar to yours, not as many positive cores, but very similar. I'm still here 11 years later. I had other things happen after that. I had recurrence and treatment, but I'm still here 11 years later. And there's always new things coming down the pipe that that'll help keep a lot of us around where 20 years ago we might not have made it this far. So take that into account also. So yeah, like Rick said, get that second opinion. Let us know what Dr. Epstein thinks.
Okay, I sent in like I had to enter my information in an email. I think I did it Friday. I thought I would hear back from them today, but didn't. So anyway, I'll follow up on that.
We really have to move on because I know there's a couple more guys who have graduated from AS and people who have questions, but pick up the telephone and dial the number, and maybe Dr. Epstein will pick up because sometimes he does. So don't be surprised. Don't be surprised if they pick up and say Epstein here, because it could be him.
Okay, well, let me just say thank you very much. I really appreciate the forum, the feedback, and it's really helpful. Thank you.
Yeah, come back and let us know what's going on. We've got your email address, so you'll get some reminders from us about the groups.
Great.
And I'm going to throw in another group for you under 60 prostate cancer, which is another group that I run.
Well, the only thing with that is that is for guys who have stage 3 and stage 4 cancer, which we don't, which we hope you don't. So we don't want to throw you into that group if you don't, because you'll be hearing stuff you don't want to be hearing. If it
We do have
turns
some
out,
advanced. You're right. We do have advanced guys in there, and I
it's only for advanced guys right now. We don't run a group under 60 group for men with T2 cancer, T1 or T2 cancer. So that's why, because it's been on my mind. Oh yeah, I'd like to get you into that group, but you're welcome to come in, but you may hear stuff that's going to be disheartening to you, but you may not, but you'll get good support from the guys. The meeting's on Thursday in this room at 8 o'clock now, right? Same time. We moved it, right, Bill?
Yep, 8 o'clock. Well, I'll tell you what, Eric, since I mentioned it and I forgot about the advanced cancer in there, I'll be happy to talk to you about being a younger guy diagnosed with prostate cancer. Very similar path to yours. So you can talk you can talk to me.
I really appreciate it. I want to make space for others. So thank you very much.
All right, come back. Don't be a stranger. All right, we're going to move on. We're doing all right. Mr. Lawler, you were first on my list to tell me that you graduated from active surveillance. So
yes, I have graduated from active surveillance.
What was the cause of your graduation? I think I'll go straight to that first.
Yes, at the last time I attended the AS group on Wednesdays and was reviewing my most recent pathology report with the group, Rick suggested maybe that I should move over to this group, and that maybe AS wasn't my.
So you got another biopsy?
I had yes, I had a biopsy in February of 2026, which would be the fourth biopsy, because I was originally diagnosed in June of 2017, almost 9 years ago now.
Yep.
And at that time I had 4 3+3s, and it was a random 12-core sample. And then again in 2020, there was a repeat biopsy, and we added one more core, so we now had 5 3+3s.
So what was your current one? The February biopsy. That's the one we're really concerned about.
Yep, I get it. We have 4 3+3s and 3 3+4s. One is 10% pattern 4, one is 10% pattern 5, and one is 10%. The other one is 10% pattern 4.
Okay.
And the reason the dream team wanted to, I've been working with a AS guy at MGH in Boston here, Tony Zeitman, and he retired. He put me on to somebody else who wasn't quite in the active surveillance arena, and they were citing the reason for taking me out of the low risk into pushing into intermediate risk was that my PSA number had gone into double digits.
Okay.
So they were no longer.
What's your PSA now?
The last one that was taken was 14.73 in April. In October of 2025, it was 12.98. And previously to that, it was in the 8s for years.
Okay, so it's been slowly creeping up.
Slowly creeping up.
Yeah.
And that's the reason the dream team, an alternate urologist and a medical oncologist and a radiation oncologist were no longer going to endorse active surveillance and wanted me to look at treatment.
So you just said that the other three cores that were 7s were 3+4s, right? All of them?
Correct.
Okay. And as David pointed out earlier, which we should always ask, there were no mention of cribriform or intraductal or any of those conditions.
Patent 4 in this case lacks large cribriform morphology, intraductal carcinoma not identified, perennial invasion is identified.
What was identified?
Perineural.
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 I don't know how to pronounce that.
Neither do I.
Perineural was identified.
Correct.
Invasion, it said, right?
That was the word. So subsequent to meeting with the dream team, they pushed me on to the head of radiation oncology at MGH, and he ordered a PSMA
PSMA.
and I got the result of that back as recent as Friday, this past Friday, and there's the thing that is now of concern is that they found their solitary small PSMA avid sclerotic focus in the left iliac bone, highly suspicious for metastatic disease.
They said it was small.
Small. Solitary small PSMA avid sclerotic focus in the left iliac bone, highly suspicious for metastatic disease.
All right. So have they made any suggestions to you about treatment or anything to this point?
Well, the radiation oncologist who delivered this news to me on Friday said he wanted me to hook up with the medical oncologist, and the first appointment I can get with her is not till next week. And he also recommended that I make an appointment with a medical oncologist and a radiation oncologist at Dana-Farber.
Right.
I know, but I can't see.
Right. So Bill, what I would say is this isn't the right group for you either. We need to put you in the high risk recurrent metastatic group, which meets tomorrow at 6 o'clock Eastern.
Mm-hmm.
And we will give you suggestions as for doctors to see at Dana-Farber. Who is the medical oncologist he's recommended at MGH?
At MGH, the medical oncologist is Christina Cornier.
Yeah, I don't know her. I mean, I think Smith probably is I'm pretty sure it's Smith. Smith's probably the go-to guy if you're going to see anybody there. But I kind of would rather see you run over to Dana-Farber, and we can give you names of some very good GU medoncs there.
Yeah, the name they gave was Adish Choudhury.
Funnily enough, that's who I was going to say. I would send you to Atish. And that's a very, very good choice. Why? So AnCan goes back a long way with Dr. Chowdhury, and he is very concerned about quality of life and not over treating. And if I recall, you're 80 years old, isn't that right?
72.
Oh, 72. Excuse me.
Rick, you added a few years there.
I added a few years. I still would say Atish is a great doc. We will give him a heads up that you're coming if you want us to, but I'd like to take this conversation out of this group and move it to the group for tomorrow, and we'll get you sorted.
Yeah. Sadly, I can't join you tomorrow night, but
Okay,
Okay,
well,
well,
when
there's
you
a,
can,
they meet every week, so.
so we meet every week, and if you can't join us tomorrow night, the meeting after that will be the 15th.
I'll be there.
Which would be Monday.
And so we meet first and third Mondays, second and fourth Tuesdays in that group. The times are different. First and third Mondays are at this time, second and fourth Tuesdays are 2 hours earlier.
All right. So
Tomorrow's group is at 6 o'clock Eastern. And so, yes, and we'll make sure, and we can work some back channels. And who was the radiation oncologist they sent you to? D'Amico?
D'Amico, yes.
Okay. So if you can get into D'Amico and Chowder it, what I would do, forget MGH, start getting your ducks in a row to get to D'Amico and Chowdery. And we don't know D'Amico that way. He knows us, but not as well. With Atish, if he doesn't give you a quick appointment, I'd be happy to write him a letter. He knows us really well.
I have appointments with both of them on the 17th.
Okay, well then that's very good.
So, yeah, as Rich mentioned, with the suspected metastasis to a bone already and the perineal, the advanced group is probably going to serve you much better. Unfortunately, it's a little higher graduation than you expected, right? But fortunately, you'll be in good hands with the group, and there's other men in there that, as most of our groups, you're going to find guys with parallels that are going to be able to give you advice on what they went through. So
right. And if you're willing to travel, there's a really, really good clinical trial going on right now that might suit you, where you could avoid hormone therapy. And so before you make any commitments with Atish, in fact, if I do write to Atish on your behalf, I will tell him that we think you might be a good candidate for this trial, but you're going to have to. It's only in one location, and but it's a really cool trial, and it might set up very well for you.
Okay, where is it?
UCLA.
Okay.
Okay, in Los Angeles, but there is provision in the trial to do scans and blood tests locally.
Got it.
But
where you at, Bill?
So let's move along, because I really don't want to talk about metastasis in this group. But
yeah, I just wanted to curious where Bill was at as far as traveling.
I'm in Boston.
Oh, Boston. Okay. All right. So I guess we'll see you on Monday the 15th.
Correct.
All right.
If you want to read, Bill, if you want to reach out to me, I'd be happy to talk to you more about the trial outside of this. But I think it's a perfect trial for you. Your disease moves very, very slow. You were diagnosed 8 years ago?
9
years ago. This is a perfect trial for you. Perfect. And so you can send me an email and a telephone number to rd@ancan.org, and we can start talking about this possibility.
Very good. Thank you, man.
You're welcome. All right, Jay, you also came over from active surveillance?
Yes, I did. I met quite a few times last year. I have to say, I've never found anything in life that you had to be more of your own advocate. I had to tell my urologist about Decipher, about getting a second opinion by Dr. Epstein, about active surveillance. It was just like I was teaching him.
Yeah. So what brings you to our group versus active surveillance? What led to that?
Was only on it for 1 year, diagnosed last February. So I had my yearly MRI. And this year it was an MRI guided, I had the MRI, my PRADs went up from 3 to a 4. They were stable size. They're all very small, 0.3 and 0.4 centimeters. So instead of an ultrasound guided biopsy that they did last year, I guess because of the PRADs increase, they went to an MRI guided biopsy. And last year I had 12 of 12 cores positive. So 1 3 plus 4 and 11 3 plus 3s last year. My Decipher was only at 0.32 last year. So therein lies why I was borderline, but I went on active surveillance. So this year, the MRI guided biopsy, he took 4 extra samples. So I had a total of 17, 13 were positive. Interestingly enough, to show you how things can go wrong, the 1 3 plus 4 core I had last year came back with no sample present. So I asked the doctor, where's my sample? I said, well, I know I took one, pathology must have lost it. So I have no idea what my 3 plus 4 was a year later.
All right.
So I had 11 3 plus 3s this year, 1 3 plus 4 at 35%. And here's the kicker. One of the extra samples, it was not on the grid of 12, was a 3 plus 5. But it was only less than 5% of a 5. I went from no perineal invasion to I had perineal invasion this year. Still no cribriform. And so I sent the 3 plus 5 off to Decipher, and I was very shocked. It was only a 0.19. So I was blessed that it was very low. I did send all my samples off to Dr. Epstein. There was no change. He confirmed everything. It's still less than 5% of a 5. In April, I had a PSME PET scan, and I have no escape, no metastasis. So I met with Tulsa Pro up in Kettering, Ohio, at the Kettering Health Center. A friend of mine from church was patient number 1 on their Tulsa machine. And everything I read on the Mayo Clinic website said, yes, you can do full gland ablation. So I went and met with the doctor up there, and he did not recommend Tulsa Pro for full gland abrasion, nor my grade group, my Gleason 5.
Right.
So I had to change course. And so I really wasn't happy with my urology group due to the fact that I had an ultrasound guided biopsy the first year, which I think missed some of the cancer. The Dr. Kettering thought, I said, do you think it grew in a year, or do you think it was due to a more accurate biopsy? And he thought it was due to a more accurate biopsy. I don't know why they don't do MRI guided biopsies every year. I think that was a mistake. So,
yeah, well, we definitely recommended the MRI fusion guided biopsies over any type of blind biopsy or even the ultrasound biopsies. It just should be the gold standard everywhere. So
I could have been dealing with this last year if I really had the 3 plus 5, which apparently I do. So Tulsa Pro was out. So I changed course, and I went to the University of Cincinnati looking for proton therapy at the Barrett Cancer Center. And they really didn't think I needed proton therapy. They said that it's equivalent. There's no difference between that and the photon therapy. So I'm going down the road of, I haven't had treatment yet. I had my ProStox test for sensitivity to radiation. And I guess there are 2 tests. The ones for the 5 treatment SBRT came back very low, from 1 to 6%, depending on it was GU 2 or 3. The IMRT came back 3 to 7. So both of them are very low for sensitivity to radiation issues, GU issues. I'm blessed that my prostate size is very small, 22 milliliters. ED I've only been married for the second time 5 years, so ED's quite important to me, of course, along with the incontinence. So Right now, I was looking at 28 sessions of IMRT. They have a variant true beam machine. It would be 28 sessions of 2.5 grays for a total of 70. I did request the Barrigel, which I guess is their version of SpaceOR.
Right.
And the gold fiducials. Barring any changes, I was in a little bit of decision paralysis for a while, trying to think what is best for me. I'm really, I don't want to have the side effects, especially ED. And I've asked them to go ahead and schedule. They're 1 to 2 months out for the installation of the Barrigel and the gold fiducials. Originally, so now talking ADT, he mentioned ADT. And he originally mentioned a long amount of it, 18 to 24 months. Then he said, well, if your decipher comes back low, we can reconsider. So it came back again at 0.19 for a 3+5. So I told him I do not want to have any ADT. And he didn't disagree with me. He said, I don't think you're crazy. When I did the research on AI, and I know AI is what it is, it basically said I'm looking at a 1 to 3% reduction in metastasis free if I don't do ADT versus ADT. It says my case is very nuanced because I do have a Gleason 5, but it's a tiny amount of it. But I also am bilateral, just loaded with cancer on both sides. So I was interested in what Dr. Mark said. I'm kind of came on here and said, what have people's experience been with IMRT? It sounds like maybe for the radiologist, oncologist, he's an adjunct professor at University of Cincinnati. He said he did see a little blip on the outside of my prostate, looked like it was trying to escape. And then I know with the perineal invasion, it's a little closer. So I thought the radiation, yeah.
So let's interrupt. Paraneural invasion is a false flag. Don't even, it has no meaning. It has very, very little meaning. The most amount of meaning it has is that it's associated with higher risk disease. I had paraneural invasion back in 2007, and I did a lot of digging into it. And people get very upset and concerned. We don't have great experience of cancer escaping through the nerve channels. So take it out of the equation.
Okay.
Now, if it's crib reform, if it's IDC, yes, but you're not dealing with that. The big question I have for you is, why aren't you doing SBRT?
So I read a lot on the Mayo Clinic website. That's actually how I found out about AnCan, was Jeff on the Mayo Clinic website. Anyway, I thought the treatment would be a little general, having 28 sessions of 2.5 versus 5 times the amount. The radiologist oncologist mentioned they both are equivalent as far as the standard. He said there is more data on the 28 sessions than there is on their 5 for widespread cancer bilateral and the higher Gleason score, that there's more data.
Again, Jay, I take issue. There's more data because we've always been doing IMRT, and SBRT came along and we started using it more widely around 2010, 2012. But we have enough data on it to tell us that it's non-inferior, and there's very little difference, if any, in the side effects.
He said I'm a candidate for both. I'm sorry.
Yeah. Stuart may have more. I think he does have more, and I know I have some links on the side effect differences between SBRT and IMRT. But if it were me, and I finished up doing brachytherapy in 22 sessions of IMRT. But if it were me and I could be done with IMRT, with SBRT in 4 or 5 sessions, I'd do it in a heartbeat.
He said I'm a candidate for both. It was really my decision. The only thing he said, which is anecdotal, he said some of his SBRT MRT patients have a little bit more of a roller coaster with side effects than the 28 IMRT. The short-term side effects.
Stuart, come on in. We haven't heard from you the whole meeting. You're like a mouse there.
Jay, I don't think that there's really any solid evidence that you're at any higher risk of side effects for SBRT. One of the really nice things about SBRT today is the later generation machines have very good targeting capabilities, which helps them avoid hitting the stuff that you don't want them to hit. Whether if you've got the latest generation regular SBRT, or if you've got MR Linac, which is MRI guided SBRT, we have a number of guys in this group who have done SBRT. Everything works out fine. I got a friend who's in LA right now getting SBRT, and he's basically is having no side effects. He's a little tired after one of the treatments. How old are you, Jay? I'm sorry, I didn't hear.
So one thing that they only have, they do not have the MRI guided Linac machine anywhere local. This will be a CT guided, like a Varian TrueBeam type machine. So it's CT. So I know the margins aren't as tight as the MRI guided.
Well, again, the later generation SBRT machines are very good. And that sort of falls down to doctor preference in terms of, I would not basically walk away from the treatment because somebody doesn't want to do, their doctor doesn't want to do MR Linac, because if they're a good doctor and they're comfortable with the other equipment, that's really what you put more faith into the doctor than just the machine. There's no reason for you to be going for proton. The Tulsa was a bad idea for you to begin with. I would I would encourage you to look really seriously at the SBRT, just for the fact that 4 or 5 treatments and you're done. And quite frankly, I've read some stuff about side effects with radiation comes about from the volume of treatment. And so the more treatment that you do, even if it's lesser treatments each time, can actually build up. While it's counterintuitive, they can, with SBRT, they can push more gray units at you faster, and you don't experience side effects because that's not what causes it. So, just from the simplicity fact of being able to be treated quicker and be past it, as opposed to having to make the commitment of, every day, every week for a month, I would look at that seriously. And also, as far as the Barrigel goes, I would talk to your doctor as to their opinion as to whether you need it or not. We have lots of guys who have not had it. We've had some guys who have had it and the application didn't work correctly. The guy I'm talking to out in California found out after he went to the trouble of having it that it didn't work right. And so it's not a given that you need to have it. It's a function of your personal medical history and also how they interpret the targeting as to whether it's really necessary or not. My radiation oncologist, he recommends or discourages on a case-by-case basis. So don't fall in love with that.
Okay. How do you feel with the radiation option versus surgery? Radiation just seemed to be a better fit for me.
How old are you? I'm sorry.
66.
66.
Have you run
I-
the nomogram? Have you run the MSKCC nomogram that we put the link in for earlier on, Jay?
I did not. I mean, Decipher gives me those percentages. I don't know if that's accurate with the
No,
5.
no, this is nothing to do with Decipher. It's going to tell you the likelihood that you would need follow-up treatment. But I honestly think, what we know is there's very little difference between surgery and radiation in terms of outcomes. It's really a quality of life issue and a lifestyle issue. And if you're comfortable with doing the radiation, we would say stick with the radiation.
Yeah.
There's no reason to second guess yourself on that.
What do you think about my decision with no ADT?
And
due to my low Decipher score at 0.19.
I would do ADT if it was for 3 or 4 months. I would do it because you're not even going to notice it. And I still believe, even though there are people that question it, and some very good people, that it weakens the prostate cancer cells and makes them more susceptible. So I probably wouldn't be looking at more than 3 or 4 months. You're a 3+4, right?
I have 1
Yes.
3+5.
Yeah.
Yeah.
I mean, again, the 1 3+5, I wouldn't be that.
Yeah,
I
have
wouldn't
one.
let that change my. But
So-
I would, if it were me, I'd probably do 3 months or 4 months of Orgovix, because
Okay.
you're not even going to notice it. And
Yeah.
that's
If
my preference.
and if they suggested anything past 6 months, I would say no.
Absolutely not. Right.
Okay. And I
And
thought,
even up to 6 months, you probably wouldn't have very many side effects from the ADT,
yeah.
and you'd recover quicker too. So
And I'm a little concerned about the side effects, short and long term, from the radiation itself. I don't know how much the pro stocks knock down my chance of long term side effects. It sounds like
they've got a pretty good track record with the Prostock as far as the analysis they've done so far, which is interesting. I mean, I wish it would have been around when I did mine, because I had horrible side effects from radiation treatment. But I didn't have a Prostock test, and I had other concerns also. So my radiation was a secondary treatment after a prostatectomy. So it was.
Do they use the same amount of grays for secondary as they do for primary?
I had quite a bit. I guess I definitely had a course that was very similar to what you're discussing. I had more, actually. I had 35 sessions, but I'd have to go back and look at my chart to see how much I got total. So,
going back to what Stuart said, it was interesting because this, again, he's an adjunct professor of radiology oncology. He wasn't really concerned about doing the gel. He does many of them without the gel, to Stuart's point.
Yeah.
But whenever I read on Mayo Clinic, everybody says you've got to have spacer. You got to have spacer. That's going to buy a lot to save your rectum.
Okay, but again, Jay, these forums are great. They're very helpful. But there's loads and loads of people in these forums who don't know what the heck they're talking about, or they'll tell you to do what they did because that was successful. More often, they're not going to tell you're not going to hear as many people tell you what was bad, but sometimes you do. So you use them as a guide, but I wouldn't be quoting the forums. I mean, so what the advice Stuart gave you, I would quote. There are some docs who just don't want to use them at all. They don't like them because they feel that it shifts the prostate. The prostate's more likely to move with the spacer. They may not get the accuracy. There are other docs who think they're the best thing since sliced bread. The best docs are the ones who say, let's look at your situation. Let's see if you need it. If we think you need it, we'll recommend it. And if we don't think you need it, we don't. And that's what Stuart said. And so, you know, don't rely. There are too many people who just, they're not reliable on the forums. And believe me, I have a long base in the forums. Back in the day, I was on Inspire like Jeff Markey's All Over Mayo today. I got an award for it from us too. But so many people, you know, we have to correct Jeff in our meetings all the time. So I don't want you to, and you know, he's got a great heart and he's got great intention, but some of these people, sometimes they're right, but sometimes they're not right.
Yeah. One last question. With my prostate full of cancer, are you better off getting the margins from radiation than you would be from surgery where they're trying to spare nerves?
Well, what you're better off with surgery is that you know exactly what was in there. But if you don't have an issue, with being close to them, it depends where the cancer is. This is what we were saying before. It really depends where the cancer is. If the cancer is very close to the edge, you know, there are other issues. But I think you have to decide what you prefer, what you want to do.
Yeah.
You know, and frankly, if you're very concerned about erectile function, you're probably safer, at least for now, with radiation than you are with surgery.
I understand I may lose it in 3 to 5 years.
Okay. Go ahead, David.
Sorry, Rick, I just sent you a study that I meant to send to everybody. But there was a study that just came out last year having to do with just how effective is short-term ADT when added to radiation. I mean, that really is what it comes down to, right? If it only improves your chances of preventing a recurrence by 1%, why do it? If it prevents it by 50%, yeah, let's definitely seriously look into that. Well, in this study, they put guys on ADT for, I believe it was 4 months, and at 5 years post treatment. Don't quote me on that 4-month thing, but it was short. Yeah, it was 4 months, right? And at 5 years, and this was random study, everybody got radiation, half of them got ADT, the other half did not. At 5 years, those who just got the radiation, 76% of them did not have a recurrence. Those who got the radiation plus the ADT, 84% of them did not have a recurrence. So that's a difference of about 8%, which to me is like, okay, that's kind of a decent number, but it's not a gigantic number. If it were me, I would do it. Having done Orgovix myself for 6 months, it was really not an issue. My symptoms were not that bothersome. They were very minor. And for an 8% difference, and I didn't even know that at the time what the advantage might be, but for 8%, yeah, I would do it again, knowing that. But it's an individual choice.
Thanks, David.
Thank you.
And I'll put that study in the chat box, Jay.
I did it already. I've done it, David.
Thank you.
I can talk now if anybody wanted to ask me anything.
Okay, David, we'll certainly come to you if, but I think there's a few
Can I
people there.
Yeah, it might be a little timely to ask about the SBRT complications. I'd specifically like to know about that. What are the risks of impotence, erectile dysfunction, and infertility afterward?
Infertility, I don't have any numbers on that, but to be fair, David, we had several men in front of you before you even got in the group that had asked for time. So.
I apologize. I only brought it up because we were just talking about SBRT with regard to the other patients.
Understand, but it could be drawn out. We're near the end of the time anyway. I'd like to get to those guys that were here earlier and ask for time, if you don't mind.
For sure. Yep.
Yeah, and we'll stay on for you. I'll stay on for you to address these if once we've been through everybody, David. I'll be.
All right, and keeping in mind that we are near time, if you can wave it off till next time, we'd appreciate it. But if you want answers tonight, as Rick said, we'll stick around for you. Everybody else, don't feel like you have to stay on the call unless you're interested. So Brian, you were like the first guy in the room, I think, when you and Stuart in here having a chat when I got on. So
yeah, I just have a question. So I'm going to go meet with the doctor at the University of Washington on this Wednesday. It's been 6 months. First time I meet him to get this transperineal biopsy. And so I'm going to meet with him. I've got some questions I'm working on. He actually sent me the thing today mistakenly, thinking I was coming in this Wednesday for the biopsy. So I called him and said, no, it was a mistake. So anyways, but the thing that it said, for the biopsy, it says no. So I just want to know, it's going to be the transperineal. There's nothing to really target because my last MRI was a month ago and it's a PIRADS 2. I don't know if they would target that anyways, where they found the cancer on the aquablation. But it says no clinical sedation. So do they just, that perineal biopsy, do I need sedation? It says no clinical sedation, antibiotics none needed, 1 hour office visit. I just did. They pre-sent that out on accident, but that's what they say. Is that, or do I need to be, I mean, does that sound right to you? Do I need to be sedated?
I think someone earlier mentioned sedation with a transperineal, but I'm not familiar with the process myself. I had a transrectal and I was not sedated. They did localized anesthesia.
Yeah.
The
doctors do it, but Brian, doctors do it both ways. It can be with sedation, in which case it's be in a surgical center. But there are doctors who are doing transperineal in the office with local. That's
you said
not uncommon.
You said it was tomorrow, Wednesday.
This Wednesday, I'm meeting with them. It's been 6 months.
Yeah, so if they were going to give you anesthesia to put you out, then they would send you the pre-op procedures, right? So you'd have to fast and all of that stuff if you're going to have anesthesia.
Yeah, they sent me the pre-ops this morning by accident, and I called them and said, "Oh, I didn't mean to send that out. You're just coming in for a consultation." I said, "That's what I thought," but that's what it said. Yeah, that don't do your. They sent all that stuff.
Well, I mean, are you getting a biopsy on Wednesday or?
No.
Okay, what?
I'm going to go talk to the guy, but I just want to know.
Okay.
I already know what they're going to tell me. They're going to say there's no clinical sedation. It's just an office visit. But other people have told me that I mean, do I need to be numb down there, or what kind of questions do I need to ask this guy?
I definitely recommend being numb down there when they do it.
I mean, or should I be sedated? I never had.
I can't answer that question. Like Stuart said, different doctors do it differently.
Right.
Okay. I even knew the guys who had transrectals that told me they went into a operating room and were sedated. So I was like, that's not the experience I had. So
transperineal is more harder on the body, is from what I've read. It's more difficult, more pain. So I don't know why he would say no.
Has anybody in the room had a transperineal? David, you have your hand up. So.
Yeah, I had one. I was fully sedated and it was done in an operating room. And if I had it to do over again, that's how I'd do it again. I just slept right through it and woke up, and it was not a problem.
What about you, Albert? Did you have one?
Yeah, Brian, my doctor was kind of pushing in the office. He's like, you know, most of the guys get it in the office. You should probably do it in the office. It'll be fine. I did that and I was very uncomfortable. So for my second biopsy, I insisted on doing it in the OR and they were like, okay, you can do that. But, you know, it wasn't their first option. So I just said, you know, I was too uncomfortable. I don't want to go through that again. And then they finally approved it and I went ahead with it. So maybe it's just a matter of sort of insisting.
Yeah. Okay. I was just wondering because that's kind of what I've heard throughout the months with you guys.
Yeah.
Then for them to say no clinical sedation, what does that mean? Okay.
Yeah. So, I mean, my personal preference also, if I had to do it over again, I would love to be sedated.
Yeah.
I just don't want to. I wouldn't want to go through that again. But I don't need to. I don't have a prostate anymore. So.
Okay. Yeah. That's all I had. That's all I had.
By
Okay.
contrast, I did have my fiducials and rectal spacer inserted while I was awake, and that was quite unpleasant. So I definitely would lean towards sedation.
I'm gonna tell them, and they're gonna listen because I've been working way too hard on this.
Yeah, we know from our past discussions with you that you can advocate for yourself very well, Brian.
Yes, sir.
So,
Yes, sir. I'll be here. I'll be here every week that I can be here. Okay.
All right.
Appreciate it.
So Albert, you were the next one in the room who asked for time.
Yeah. Okay. Thank you. You know, I pretty much decided on Kishan. Then I went and watched Dr. Roach's PCRI talk where he talked about flaws in the Mirage study and made me have doubts about MR Lineac. So that was disconcerting. And anyway, when I did talk to Kishan, I met with him. It was 4 months ago now. And he said, you know, you need to treat within 4 months because I do have the cribriform and I'm 3+4, but actually Mayo called me 4+3. I was downgraded to 3+4 by Epstein, but just barely because I was at 50% 4. At 51%, I would have been 4+3, even with Epstein. So yeah, go ahead.
So I was going to say, so you got Dr. Keyshawn, you got Mac Roche, and they're both rock stars, right? So at PCRI, you know, that they'll get up there, or at ASCO, they're up there, and everybody listens to them because they're the guys with the experience. But you know, AC/DC and the Rolling Stones were both rock stars, right? So
yeah,
who was the greatest? You'll never get two people to agree, right?
Yeah.
I got to say, Albert, again, if you chose Dr. Keyshawn for your treatment, and you're going to get you wanted to get MR Lineac, which I believe we've discussed with people in this room who've had it, that you're fine. You're with a rock star.
Yeah.
You know, he might be AC/DC, he might be Rolling Stones. I don't know. It depends on if you prefer England or Australia. So,
yeah.
But I mean, Albert, I say go for it, man.
Yeah, I gotta. The other thing is, you know, Roach was pitching Cyberknife, which is what he does because of all the different angles it comes in on. But I guess it's sort of like these are all really great treatments, and splitting hairs is not worth doing.
And that's what you're doing. You're splitting hairs.
Yeah.
I mean, go with
Albert,
Dr. Keyshawn.
Albert, Mac was my doc. I have a great amount of respect for him. He's quirky. He does things a certain way. You can't see Mac anyway now because he's out until November. I would say this is about you. And I'm going to talk very frankly, and you know it.
I know
You're
that.
going to look for an excuse not to make a decision for as long as you possibly can. And there's always going to be another alternative. And you're right. There's Cyberknife. There's MR Lineac. There's, I don't know what. But you have to settle on a doctor that you want to go with, and you have to put your blinders on, and you have to go with it.
Okay.
Because that's you. That's you. It's you. We can't tell you. Should I say go? Would I say go to Mac? Mac's not there. Go to Severin. Go to Alex. What's his name? Who's there? There's a bunch of other good doctors, but you've made your decision, and you can't do much better than Kishan anywhere,
Right.
right? So, to come to us and say, well, I was going to do it, but then Mac says this, and there's always going to be somebody, and you have to get treated, and you recognize that.
Yeah.
So the issue for you is not the doctor, it's making that decision and getting in your car and going up to Phoenix, or getting on the plane and going over to Los Angeles and getting it done. And I'm just going to give you some hard love. Get it done.
I know.
Because otherwise, you know what's going to happen? You're going to be like Bill Lawler.
Yeah.
Right? And
Right.
you're gonna be like Bill Lawler, who for 9 years watched it and didn't want to do this, and then the next thing, there's a lesion, and now we're dealing with a whole nother situation. And you know what? The trial I want to send him to is actually a trial with Kishan, where he may be able to avoid a lot of treatment, and we'll finish up in an MR Lineac machine. So get your ass over to Los Angeles and get treated. The next time we see you on here, we want to hear you with that you've got a treatment date.
Yeah. And you don't think I need to go to a medical?
I don't think you need to go anywhere but make a decision to do it. That's what I think. That's my decision. You can ask the other moderators or the other people who have been with you on this journey. We want the best for you.
Right. Well,
right.
The last thing I think would be, I found this guy here that was highly recommended that does the Variant Edge. We talked about that, the CT guided SBRT. And then Kishan could do, of course, we know what he does. And then, it seems like it would be the one thing that I keep getting stuck on besides these other things is if I do need follow-up, I know people go long distances like Bob from.
Okay, let's cross that bridge when we get to it. Okay, if we're thinking about what we're going to do when the treatment fails, got a problem. And there's not much difference in what you can do if the treatment fails with any type of radiation. The options are all the same. If we're talking surgery versus radiation, there are differences, but really nothing is eliminated in today's world with surgery, and nothing is eliminated in today's world with radiation. It's just an excuse to procrastinate.
So I could just go back to UCLA for follow-up if I need salvage.
If you need salvage, we'll worry about it when you need the salvage. You can go to UCLA. You can go back to Mayo. Yeah. You can go you can go to UCSF, but let's not worry about that right now. You got to get treated.
Yeah. Well, Vargas was saying 20 sessions of IMRT, and I kind of like the idea of the SBRT better.
Okay, so go up to Vargas and tell him I'll come to Mayo, but I want SBRT. They've got SBRT at Mayo.
Yeah. But don't you think I should go to Kishan because he's the best?
I think you should go somewhere and get off your duff and do it.
Yeah.
Because you're looking for these decisions. Every time you make a decision, you second guess yourself.
Yeah.
And what I'm saying is you'll second guess yourself to the point where we'll see PSA recurrence after 3 or 4 months.
Yeah.
And that's what we don't want.
Albert, I think you waited long enough.
Yeah.
I mean, seriously, man, we can go back and look at these recordings from 6 months, 8 months ago, and you're saying the same thing you're saying today.
I'm aware of what I'm doing to myself. I'm not asleep.
We understand it.
Okay.
But you know, Boykins told you. You know exactly what Boykin would say if he was here. Stewart said it. I've said it. Rick said it. Just
Okay.
and yeah, go to Keyshawn. Go to Keyshawn and get your treatment,
Go
and
to
then
Keyshawn.
come
Yeah.
back to
That's a
come
great
back to us
decision.
and tell
What's
us how
that?
you're doing. Go to
What?
Keyshawn and get your treatment. It's a great decision. You made a good decision with him. Like I said, he's a rock star.
Yeah, that's what I thought. Yeah. Okay. Thank you guys. As always, thanks again.
And like Rick said, come back and tell us when your treatment date is with
Yeah,
Dr.
right.
Keyshawn.
Yeah.
Okay?
Yeah, good.
That's what we want you to do, man.
I know y'all are like, come
That's
on.
from now on. That's the only advice we're going to give you is to
Right.
go get a treatment appointment with Dr. Keyshawn. That's the advice I'm going to give you from now on, Albert.
Yeah. Okay, good. Thanks, guys.
Don't bring up anybody else because that's the only advice I'm going to give you from now on.
Tough love. I love it.
All right.
All right. Thanks, guys.
All right, Anthony, you stuck with us this whole time.
If you want, I can wait till next time if it's kind of late because it's just a small update.
Go ahead and give us your update. You're here.
Okay. Well, I got a new PSA last week, and it actually went down. And I wanted like an explanation of that. Like in October of last year, it was 4.57. Last week, it's 3.79.
Well, Anthony, first question is, were the tests done at the same location, same lab?
Yeah.
Yes. Quest Diagnostics, yes.
Okay.
And so now my Quest changed the assay for PSA in the middle of last year. So what you need to do is look at both those reports and see if one was a Roche test and one was a Siemens test. It'll say right there on the report. So that's the first thing. You want to make sure you had the same assay for both of them. And the second thing is, and I'd have to go back and look at what I wrote for you. The notes I've taken about you so far, which my computer's acting up here. So where does that put you now, Anthony? And forgive me for not remembering your exact history right now. So
well, I had a biopsy, and I had a PET scan, and I'm going to get my results next week from Dr. Correa about the PET scan. He's going to explain that to me. But it was just that PSA.
The PSMA scan, right? So you came to us in April of this year, and you have a Gleason 7, but you didn't. You might have told us later what the 7 was, but I don't see that in my notes. You had a 4.3, right? 4 plus 3.
His concern is, why did the PSA go down?
Yeah.
Anybody want to take a shot at that?
As to why?
Yes.
Yeah.
Discussions why that could happen.
David raised his hand.
Well, just to give you my own experience, the first time I got my PSA tested, it was 8.9. And 3 months later, 2.5 months later, it was 7.1. And the next 2 months after that, it was 6.1. I still need to get it treated. So that fluctuation was a moot point.
Yeah, I kind of figured that it's probably just probably something I ate that changed the score.
Something you ate?
Yeah. I just
so
wanted to
when you had the 4 points, when you had the 4 point something, you had some spicy tamales the day before, and this time you had some yogurt the day before. They're not. It's not that vastly different. The thing that you have to focus on is the fact that you have a positive biopsy with a 4+3. So I wouldn't worry so much about your PSA dropping. It probably does not mean that your cancer's getting less severe. We put a story in. Sorry, I'm out of water too. But we put a thing in one of the reminders about a gentleman that I talked to the brother of a friend, and his PSA was high when he got his first check. And right away, he's telling everybody in his family has prostate cancer. No biopsy, no nothing. He's just like, oh, my PSA is 12. I got prostate cancer. I'm going to die. But upon meeting the gentleman and talking to him and I guess I would say, analyzing his mental state and everything, he was extremely stressed out. He had some nutritional factors too, but he had to go on antidepressants. So once he started taking antidepressants, got his diet fixed, the next time he has PSA taken, it was 3.7. Right. But since then he's had it again and it's gone up. It wasn't 12, but it was, it was higher than the 3.7. So then he got all excited again, right? So he's got a nervous nature. So it can fluctuate, and there's various things that can make it fluctuate. So I wouldn't worry about a slight drop. That drop you told me, that's not very, very large at all.
Okay.
But the fact is, you have a cancer diagnosis already, so don't focus on PSA right now.
Okay.
All right, David, you were the last guy, and Rick said he'd stick around for you. So
Yeah, just a quick question about percentages of erectile dysfunction and infertility post SBRT. I thought it was going to be a more targeted therapy, but one of the radiation oncologists was telling me, no, they kill everything and then they overkill where it's localized. And if I thought I might possibly want any children in the future, I needed to be banking firm.
Correct. So let me address that. It came up, as Stuart knows, in a conversation we had with a guy who's currently under treatment this week. In most situations with radiation, they are going to radiate where we're not talking focal therapy. They're going to radiate the whole of the prostate. They're going to radiate the seminal vesicles. To be sure, especially if you're leaning towards higher risk cancer, if you're a 4+3 or if you're high risk 4+4, they're going to be sure. They may not radiate the nerves, but they're definitely going to take out the prostate. Now, if you have kids, naturally, you need semen and you need prostatic fluid. And once they radiate the prostate, you have no prostatic fluid. It doesn't make it anymore, because that's what the prostate does. So you're going to have dry ejaculations. So that's the reason why, even if they don't radiate the seminal vesicles, there'd have to be a surgical procedure to remove your semen from the seminal vesicles, which is where they're held and kept. So the bottom line is, yes, your doctor's right. If you want to have kids and you want them with your own sperm, then you need to bank that sperm ahead of time, because most likely you're not going to be able to have a wet ejaculation going forward. Does that answer your question?
Yeah, most likely, but I would like percentages on all those things, please.
I don't have percentages, David. I mean, if you're asking me to guess from somebody who's you're asking me to guess from somebody who's had full-blown radiation, I would guess probably 95% of the time they cannot make prostate fluid afterwards.
And what are the percentages of impotence afterwards?
Well, what does impotence mean?
Erectile dysfunction, let's say.
Erectile dysfunction is a whole nother issue. Okay.
Or ability to have an orgasm, let's say.
Ability to have an orgasm, I don't know the numbers. Somebody else in the group may do. I would say in terms of erectile dysfunction, probably after it's going to be different at 2 years, at 5 years, and at 7 years, and it depends on your age. I think those numbers are out there, but I've never actually done the research. Stuart, do you have a handle on those numbers?
I don't have on the numbers, but David, what the immediate answer is when you start asking that question is your risk of ED is directly tied to your situation coming into the treatment because everybody's at a different stage.
Yeah, everything works fine right now.
How old are you, David?
65.
Okay. You know,
Yeah, go ahead.
you know, I'll tell you, I'll tell you what my radiation oncologist told me. And the other thing which I would recommend that if you're really interested on this, is if you haven't already, I would go track down the information that's been published by Dr. Mulhall at MSK because he's probably the most expert person on this subject on the planet. Mulhall. He's written the book on it. But, what the radiation oncologist will tell you is that it's most likely that you are going to experience some degradation in performance. You are most likely going to lose any liquid ejaculation. Yes, you will still be able to have an orgasm totally separate from everything else because that is a totally separate piece of it, and the everybody's different, and go through the research, but you should expect that under any circumstance there's going to be some impact.
Okay, and then
David in Portland has something to add to this.
I heard Mark Scholes, who's a medical oncologist in Los Angeles, address this topic, and he had kind of an interesting way of looking at it. He said that for men who have not had prostate cancer, impotence is defined as being unable to achieve an erection without medical help, without Cialis or something like that. But for men who've been treated for prostate cancer, particularly radiation, the definition changes. Impotence is being unable to achieve an erection with Cialis. So that's kind of the difference.
yeah, no, what I really want to see, and I've got some training in medical statistics. What I really want to see, and I think I would have liked to have seen it from my doctors originally, and I asked them for peer-reviewed work. I want to see what the percentages are and the factors are if for somebody who has prostate cancer, whether they undergo treatment or they don't. I guess that would be the clear control group, and then you can compare it to the regular male population as well.
Yes, so
My doctor, they're not having the grown-up conversation, which seems to be hard to get anyone to do. The younger radiation oncologist had this when I pressed him, tried to get some questions answered, but they hide behind this stupid shim survey, and just because I don't currently have a partner, they seemed entitled to use my body to pay for their new machine, and I'm like, the communication was lacking at a level I wanted it.
So yeah, David, I would hazard to say that someone has those numbers somewhere on the internet. I mean,
and I think
PubMed's probably a good place to go and look for research into that from one area. But I mean, from a sample of one, I will tell you, I was 52 years old when I was treated, and as you said earlier, everything worked fine. I had a prostatectomy, I had recurrence, I had radiation treatment, I had 24 months of ADT, and I had some other extenuating circumstances. I'm now 63, and it took some work, but everything works fine. So
Oh, good.
everybody's different, man.
Yeah, I did a little searching and I came up with like 30 to 70%. Um, sorry, was it Bill? Were you saying 2 years, 5 years, 7 years?
That was Rick.
I'm sorry. Okay, there you are. I can't.
So
Very small.
David, have you been in our group before?
Not this one. I've been in the active surveillance twice now. I missed you
Okay,
guys
yeah.
on Memorial Day. I put some of my information in the chat earlier. I'm gonna go see Dr. Liss. I've got a second opinion appointment at UCSD, and I've talked to Dr. Epstein, and I'm gonna get my samples. But honest to God, I asked my doctor 3 weeks ago for online access to their Follow My Health portal, and they haven't done jack shit. So I'm gonna have to go there personally tomorrow and get it done. And my urologist is nominally in the same group with the radiation oncologist, but they're at different locations, and neither one of them seem to have a functioning online portal or be in communication with each other. So
Sorry to hear that. Sometimes it does take that in-person touch to get things done. So
yeah. Well, they're on the older
all right.
side.
Well, I'm sorry we didn't have those specific answers for you. Like I
no,
said,
that's okay.
it's really hasn't been it hasn't been a big area of focus for the majority of men that come through AnCan. But then again, the majority of the men in these groups are a bit on the older side also. So
Yeah, I
take
just
that for what it's worth.
I think it should be part of informed consent. Is my personal moralistic view of this whole thing. Yeah.
So Dr. Liss is great. He's very upfront. He's straightforward. You need to come out and tell him upfront what your concerns are. You know, the
Oh,
second,
and what? Yeah, and what I'm really upset about was if I needed.
hold on a minute. Hold on a minute.
Go ahead.
The second opinion for you is very, very important. So what I would be totally focused on right now, is getting a second opinion from Epstein on that biopsy. You have 2 out of 16 cores. One of them is 4+3. If that turns out and Epstein comes back and he says that, well, you say, I'm reading here, 2 out of 16 cores were 4+3 and the others were 3+3. So you have 2 4+3. If it turns out that those 2 4+3s are not 4+3, it's a whole nother ball game. So
that's all. That's all in the works. I tried to get it, as I say, I tried to start that 3 weeks ago.
Well, for me, I'd wait to see Dr. Liss until you have that second opinion from Epstein, because it's going to be it's going to make it different. You know, you're going to need to go back and see Epstein if he comes back and says it's 3+3. And if he says it's 4+4, it's another story again. So I think you've really, really got to get that second opinion from Epstein first. I would say this, that you're not, I mean, I would suspect you are not a candidate for any type of focal treatment.
That's what the urologist said initially, but at this point, I don't. Anyway, if I needed to be told I should be banking my sperm, they could have done that a year ago, and nobody did. And that's what I'm really upset about.
Okay, but you haven't had treatments, and you can still bank your sperm. So, so don't get upset about. Don't get upset about it. You know, I mean, yes,
no, but I could be having treatment if I'd already banked everything. So, yeah.
Okay.
But I mean, if you, like Rick said, get that second opinion, and you might not need any treatment that would affect this area. So
that's fine. There's just a failure of communication here.
How old are you, David?
65.
And you want to have kids?
You know what? I've been coming through some other medical things, and I'm looking back at the last 20 years of my life as pretty much wasted. So there's a lot of regrets. And if I could do it all over again, would I? Sure. But I'm thinking more in the terms of donation or maybe So anyway, I don't know.
Okay. Yeah, I was just curious about that. I'm 63.
Either
and,
that,
I-
or this might give you too much of an insight into my personality. But one of my thoughts is I want to annoy as many people on my way out as I can. So if I were to donate to a foreign mother who wanted to take payment, I'm thinking that might be a good way to piss off my ex-wife. Anyway,
these sessions are recorded, David. So
I don't care. Other advantage
all right.
of
So
getting
I hope
well, you
we've
don't
helped
have
you
to
out
put
a
it
little
all in the
bit.
transcript, right?
I
Anyway,
hope we've helped you out a little bit. So so
what's
David
that?
was the last person with questions.
Thank
We've
you.
gone a half an hour over our 2 hours, and appreciate everybody sticking around who did stick around. As I said before, don't ever feel like you have to. If you got something to do, go ahead. It's anybody can leave early except the moderators. And I say that as one of the bosses at AnCan. So
Before you go, can you put that link in for the nomogram again?
the nomograms.
Nomograms, yeah.
Yes, scroll up. It's right there. You need to scroll. If you scroll up, you will find it. Stuart put it in. It's about a third of it's about halfway up.
I put it in new. It's the last one in there now.
Okay.
Okay, got it.
All right, gentlemen, I'm going to stop the recording.
Hold on a minute, but Mr. Burns had his hand up, so everything stopped.
I
Everything
did not
stopped.
recognize that. I'm sorry, Greg.
Everything stops for Mr. Burns. Go on, Mr. How are you, Mr. Burns?
He said stop the recording. So.
Stop the recording.
Okay.
Stop the recording. No, listen, guys. I just I've been listening in, and just just stopped in to say how I have to say I got